This lecture will go over Chapter 18, Depressants. The main categories we're going to talk about are sedative hypnotics and general anesthetics. Sedative hypnotics can be used to aid a patient who may have difficulties with sleeping. So the first slide here that we're going to talk about talks about the stages of sleep. Normal sleep is composed of two definitive phases, rapid eye movement and non-rapid eye movement sleep. Both REM and non-REM sleep occur cyclically at about 90-minute intervals during sleep. Individuals perform better during their waking hours if they experience all types and stages of sleep. During REM sleep, individuals experience most of their recallable dreams. It's difficult to rouse a person during REM sleep. And if the person is roused from REM sleep, a vivid, bizarre dream might be recalled. Before medications are used to treat sleep disorders, non-pharmacologic management should be tried by the patient. So we'd want to, as nurses, be teaching our patients these tips to help promote sleep. Arising at a specific hour in the morning, taking few or no naps, avoiding drinks that contain caffeine or alcohol 6 hours before bedtime, avoid smoking nicotine products for 6 hours before bedtime, avoid heavy meals or strenuous exercise before bedtime, take warm baths and listen to quiet music or perform other soothing activities before bedtime, decrease exposure to loud noises, avoid drinking copious amounts of fluid before sleep. Obviously, drinking copious amounts of fluid would lead to the patient awaking from sleep in order to use the restroom. And then finally, drink warm milk before bedtime. Some of the classifications of sedative hypnotics that we're going to talk about include barbiturates, benzodiazepines, and non-benzodiazepines. On page 234, you have a table 18.1 that goes over the common side effects and adverse reactions for sedative hypnotics. And those I'm going to task you with looking over on your own, understanding what they mean, what is a hangover, being able to match the definition with the name, and getting familiar with those. So I'm going to let you review those on your own. The first classification we're going to talk about is barbiturates. They can be long, intermediate, short, or ultra short acting. There is the restricted to short-term use because of the many side effects, including drug tolerance that they have, usually limited to 2 weeks or less. Barbiturates had been the drug of choice. They came about in the early 1900s, but when benzodiazepines became introduced, they have less side effects and whatnot. They then became the drug of choice, so barbiturates sort of went by the wayside and aren't used quite as often. Many drug interactions are associated with barbiturates. Alcohol, narcotics, and other sedative hypnotics used in combination with barbiturates may further depress the CNS. So it's sort of like the previous chapter we talked about stimulants. We're worried about combining stimulants with stimulants. For this chapter, we're worried about combining CNS depressants and having a negative effect on the patient. If you look at the drug chart, drug table 18.2 on 235, phenobarbital at the bottom is the prototype barbiturate that I want you to be familiar with. If you look, they all end in barbital. That's your clue that you're dealing with a barbiturate. When you hear about the classification of benzodiazepines, a lot of times you think of medications that are used to treat anxiety or panic attacks. In terms of this chapter, we talk about benzodiazepines for treating anxiety and things of that sort that may cause insomnia. So it's going back to being used as a medication that can help promote sleep in the patient. Sometimes a patient is going along and having a dandy life and something just rocks their world, like the death of a parent or a child, and they just need something temporarily to get through that bad time, and it's because of that anxiety and that change in their life that's causing the problems with sleeping. And in those instances, a benzodiazepine may be prescribed for the patient. If you look at the benzodiazepines listed there, your prototype is alprazolam, brand name is Xanax, if you want to try and link it together and remember what it does. Alprazolam is your prototype drug on 235, but you can see that all the benzos end in LAM or PAM. So if you see a drug that's ending in LAM or PAM, you should immediately be thinking that it's most likely a benzo, and you know what benzos do. How does it work? The action. The benzodiazepines increase the action of an inhibitory neurotransmitter, gamma aminobutyric acid, or GABA, to their own receptors. The neuron excitability is then reduced. Again, used to treat anxiety, and by treating the anxiety, we can help promote sleep within the patient. Again, benzodiazepines should be used, or they're not intended for long-term use. They should be used for no longer than 3 to 4 weeks. Patients taking benzodiazepines can experience vivid dreams or nightmares. Sometimes they experience sleep-related behaviors such as preparing and eating meals while sleeping, sleep driving, engaging in sex, or making phone calls during sleep without any memory of the events. Alcohol and other CNS depressants increase the risk of sleep-related behaviors, and you'd want to encourage the patient not to take the medication with alcohol or other CNS depressants. If you look on page 236, under the benzodiazepines, it lists the benzodiazepine antagonists. And if you think about it, what an antagonist is, right? It's a blocker. So that is your benzodiazepine antidote if you had an overdose. So let's say I took too many alprazolam, I've overdosed on alprazolam, I'm experiencing respiratory depression. The prescriber, the physician, would order flumazenil as an antidote to my benzodiazepine overdose. Go ahead and look at the purple nursing process box for benzodiazepines. Pause the video and pull out what you think is most important, the most important information for benzodiazepines. So under assessment, we want to get a drug history for the patient. We need to know if they're taking medications, other CNS depressants, which could potentiate respiratory depression and hypotensive effects of the benzos. We want to get vitals for baseline, get a good history and description of their insomnia and anxiety disorders, and then assess renal function. Impaired renal function could prolong drug action by increasing the half-life of the drug. I'm going to let you look over nursing diagnosis and planning on your own. If we fast forward to nursing interventions, we want to monitor vital signs, especially respirations and blood pressure. Again, benzodiazepines, the chapter that we're dealing with, are depressants. So it's going to turn down the body, so our respiratory rate may decrease, our blood pressure will decrease, and we're going to want to be monitoring those to make sure it doesn't become problematic for our patient. We want to use a bed alarm for older patients or patients receiving a hypnotic for the first time, because confusion can occur. We worry about safety. We don't want our patients to injure themselves. We want to examine the patient's skin for rashes. Skin eruptions may occur in patients taking benzodiazepines, so monitor skin. Under patient teaching, again, go back. Step 1 should always be teaching the patient the non-pharmacological methods to induce sleep. We had already gone over those, so you can review those again. We want to encourage the patient to avoid alcohol, antidepressants, antipsychotics, opioids, any other CNS depressants while taking benzodiazepines. Advise the patient not to drive a motor vehicle or operate machinery when using benzos. Under side effects, advise the patient to report any adverse reactions such as cognitive changes or paradoxical reactions to their healthcare provider. Teach the patient that benzodiazepines should be gradually withdrawn, especially if they've been taken for several weeks. Abrupt cessation may result in withdrawal syndromes such as tremors and muscle twitching. The next category we're going to talk about is non-benzodiazepines used as sedative hypnotics. Zolpidem tartrate is your prototype drug on 238. It is a non-benzodiazepine that differs in chemical structure from benzodiazepines. It's used for short-term treatment, usually less than 10 days of insomnia. Sometimes you'll hear about providers prescribing it for longer time frames, but just for our sakes, it's recommended for short-term treatment, usually less than 10 days. If you look at page 236, Zolpidem tartrate is the only non-benzodiazepine. That's your prototype that I want you to be familiar with for testing purposes. In terms of the older adult, we want to make sure that we're identifying the cause of insomnia in the older adult and that we're really focusing on non-pharmacological methods before sleep medications are prescribed. Because of the physiologic changes in older adults, the use of hypnotics can cause a variety of side effects. Barbiturates increase CNS depression and confusion in older adults and should not be taken for sleep. So barbiturates, again, should not be taken for sleep in older adults. Long-acting hypnotic benzodiazepines should also be avoided. The main sleep problem experienced by older adults is frequently nighttime awakening. Sometimes it may be discomfort or pain that's causing problems for the older adult with sleeping. So occasionally a non-steroidal anti-inflammatory drug such as ibuprofen may be taken to help alleviate the discomfort in the patient and can help promote sleep. In terms of the benzodiazepines, I just want you to know that long-acting is not preferred for older adults, that short to intermediate-acting benzodiazepines would be preferred. And I'm not worried about you knowing the specific names, but just recognizing that short to intermediate-acting benzodiazepines are preferred for the older adult. This final classification, we're going to talk about melatonin agonists. Ramelteon is a category of a sedative hypnotic called a melatonin agonist. It is not classified as a controlled substance. All the other medications we talked about, phenobarbital is Schedule 4. Alprazolam is Schedule 4. Zolpidem tartrate is Schedule 4. So this is the only one that's not considered a controlled substance that can be taken to help improve sleep. The adverse effects are listed there for you to review on your own. Go ahead and look at the purple nursing process box for non-benzodiazepines and pull out what information you think is most important. Under assessment, we want to get a good idea of what the patient's sleep problem is, get baseline vitals and lab tests, some liver function tests. We want to obtain a drug history. We're worried about the patient combining CNS depressants and then experiencing respiratory depression because of that. Nursing diagnosis, you can check out on your own. Planning, the patient will remain asleep 6 to 8 hours would be our goal with medications. Nursing interventions, again, vital signs, checking for signs of respiratory depression, including slow, irregular breathing patterns, monitoring pulse ox, all that good stuff. We're worried about patient safety if they experience confusion because of the medication. So bed alarms should be used for older adults and patients receiving non-benzos for the first time. Observe for side effects such as hangover, lightheadedness, dizziness, or confusion. Under patient teaching, teach the patient again to use the non-pharmacological methods to induce sleep. Tell the patient to avoid alcohol, antidepressants, narcotics, any other CNS depressants when taking a non-benzodiazepine. Patients should take the medication, the non-benzodiazepine, before bedtime. It takes 15 to 30 minutes to take effect. And we'd also want to encourage the patient to urinate before bedtime to help prevent sleep disruption because the patient has to get up and use the restroom.